Hello, my name is Maxine. I'll be your tutor. Welcome to Module 1.2, Vectors and Waveforms. This is a free module and I hope you enjoy the presentation. Our teaching philosophy at Cardiorhythms is very simple. Although our seminars are intensive, they are also very relaxed. Clinical case studies are of utmost importance in this teaching method. It fosters a more hands-on approach, whereby each student can effectively practice what they have just learnt in theory. The emphasis is then that the student internalizes the information, rather than simply memorizing facts. Our goal here is then that the student is motivated and will want to continue in their studies. We believe there is no such thing as a bad student. Teachers work for their students, and we are committed to making your online learning experience as rewarding as possible. In Module 1.1, we looked at some basic cardiac anatomy and physiology to better understand how the heart functions, both mechanically and electrically. In my experience, ECG interpretation is much easier if you understand exactly how the electrical conduction system works. By the end of this module, you will understand the individual waveforms, measurements and intervals, and know exactly what they signify in relation to the electrical conduction system. You will also understand the ECG graph paper, how vectors work, and how to calculate heart rate. For a quick review of the conduction system, please click here. So let's review the conduction system again. Normally, the electrical impulse is initiated at the SA node. It travels through the atria, which ultimately results in atrial contraction. The impulse then ends up at the AV node, the gateway between atria and ventricles, and is delayed slightly. It travels down the bundle of His, and then simultaneously down the right and left bundle branches, the latter dividing into the anterior and posterior fascicles. The impulse then finally ends up in the Purkinje system, resulting in ventricular contraction. So what does the ECG do? Electrodes placed on the body pick up the electrical signals generated by the various parts of the conduction system. This then may be transmitted to a monitor or onto graph paper. The ECG is made up of several waveforms which represent the cardiac cycle, or one heartbeat, as shown here. Let's put some markers on the main components. Hover over the marker to reveal the name. Click the marker for more information. The isoelectric line is the baseline voltage. The amplitude is 0 and therefore represents neither a positive nor negative electrical potential. So, anything above this line is considered a positive waveform, and anything below the line is considered a negative waveform. The isoelectric line is best seen between cycles, i.e. after a T wave and before the next P wave. However, we can also see the isoelectric line between the P wave and the QRS complex, and between the QRS complex and the T wave. The first wave we encounter in the cardiac cycle is the P wave. This represents electrical activation of the atria, also known as atrial depolarization. This then leads to atrial contraction. The QRS complex represents electrical activation of the ventricles, also known as ventricular depolarization, which in turn leads to ventricular contraction, also known as systole. The QRS itself is composed of two or more separate waveforms, Q, R, and S, which may or may not all be present. We will be looking at QRS complexes in more detail later on in this presentation. Following the QRS we have the T wave, and this represents repolarization of the ventricles, leading to ventricular relaxation, also known as ventricular diastole. One common question I'm asked is, what about atrial repolarization? Well, of course this does occur, but is usually not seen because it's buried within the QRS complex. Occasionally you will see a low voltage wave following the T wave, and this is known as the U wave. Nobody knows for sure what the U wave represents, but it can be seen in normal patients, especially those with slower heart rates. And it may also be seen in patients who have low potassium. Here is an ECG example, and we have a fairly slow heart rate here. This is our P wave, and this is our QRS complex, which happens to be directed below the baseline. More about this later. Here is our T wave, and just after you can see a small flat wave, which is the U wave. The ECG is recorded on graph paper that is divided into 1 mm lines, or as I like to explain it, the small boxes, and into darker 5 mm lines, the large boxes. The height or depth of a waveform or segment is measured vertically. This is very straightforward. Each small box is worth 1, and each large box is worth 5. For example, we might want to measure the height of a QRS complex, or the depth of the ST segment. Duration is measured horizontally. For example, we may want to measure the length of an interval or pause. Given that the recording speed is normally 25 mm per second, one big box across is worth 0.2 of a second. Therefore, 5 big boxes across is worth 1 second. The QRS complex is composed of 2 or more separate waveforms. When learning ECG interpretation, you will nearly always be presented with this type of diagram. You will then learn the following information. A Q wave is the first negative deflection, an R wave is the first positive deflection, and an S wave is a negative deflection, which technically should fall below the baseline and follows an R wave. Here are some other QRS complexes you may encounter. However, whether or not each part of the QRS is present, or includes additional waveforms such as an RSR pattern, it is common to identify the ventricular waveform as a QRS complex regardless of the components within it. For example, we would generally refer to this complex, which is labelled RS, as a QRS complex. This is by no means representative of all ECG textbooks, which vary in their methodology. However, I find it useful to give tall or deep waves capital letters, and small waves small letters. The reason I do this is because Q waves can be very small and benign. These are often referred to as septal Q waves, and are a normal finding. However, Q waves can also be deep and wide, and deep Q waves can be a sign of myocardial infarction. Second R waves are usually represented as R'. RSR or RR complexes are usually seen in bundle branch plot patterns, or in rhythms arising from the ventricles. By all accounts, if the conduction system is working normally, the QRS duration should be less than 0.11 second, approximately 3 small boxes. If less than 3 small boxes, the QRS complex will appear narrow. If it appears any wider than this, or there are wide deep Q waves or additional R waves present, it usually indicates an abnormality. We already know now that the duration of the QRS should be less than 3 small boxes. Let's take a look at some of the other important intervals. These are the time periods between the separate waveforms. Hover over the shaded sections to reveal the name of the interval. Click the sections for more information. The PR interval is the time period from the beginning of the P wave to the beginning of the QRS complex. It basically represents the time it takes for the impulse to travel from the SA node to the AV node. This includes the delay at the AV node. The delay by itself is specifically known as the PR segment. The PR segment in a normal subject is isoelectric. In other words, it should be found on the baseline. Normal duration of the PR interval ranges from 0.12 to 0.2 seconds. In other words, the PR interval should be no shorter than 3 small boxes and no longer than 1 large box. You might be asking why the PR interval is not called the PQ interval. Well, actually, either terminology can be used, depending on whether there is a Q wave present. However, in my experience, the term PR is much more ubiquitous regardless of what waves make up the ventricular complex. The ST segment is the section from the end of the QRS complex to the beginning of the T wave. In a normal subject, the ST segment should be isoelectric. Therefore, it should be found on the baseline. It represents the period when the ventricles are between depolarization and repolarization. The ST segment is extremely important as deviations from the baseline, such as elevation or depression, are clinically significant. You might want to check out the ischemia and myocardial infarction module for more information on this. Measurements of any ST segment deviations, height or depth, are measured vertically. Remember, each small box is worth 1 mm and each large box worth 5 mm. The QT interval is the section from the beginning of the QRS complex to the end of the T wave. It represents ventricular depolarization and repolarization. This interval varies with heart rate and with electrolyte abnormalities. This interval is important because a prolonged QT interval can potentially lead to dangerous and life-threatening arrhythmias. When measuring the QT interval, it should be corrected for heart rate, and we call this the QTC. A normal QTC is usually equal to or less than 0.4 seconds, which is 2 big boxes. For arrhythmia recognition, it's really only necessary to view a rhythm strip. On a 12-lead ECG, the rhythm strip is usually displayed at the bottom of the ECG paper. The lead that is chosen for the rhythm strip will determine the direction of the PQRST waveforms. Very often we use a lead 2 for rhythm strips. There are 2 reasons for this. Firstly, a lead 2 usually allows for good recognition of P waves. And secondly, it usually faces the wave of depolarization. In other words, it normally gives us positive waveforms. Let's look at this in more detail. Here we are looking at a person straight on. Therefore, this is the left arm, and this is the right arm. The wave of depolarization is the overall direction of electrical flow. Therefore, because of where the heart is situated, the average wave of depolarization beginning at the SA node and ending at the apex will be downward and slightly toward the left side of the person. Lead 2 always views the heart from this position. Because the electrical impulse in a normal subject is moving toward this lead, it gives us a positive waveform. If the impulse is moving away from an electrode, for example, this is normally the case for lead AVR, it gives us a negative waveform. There is a free module on our website called the 12-lead ECG, and this contains all the information you need regarding specific electrode placement and the various vectors associated with that. For now, just understand that any impulse that moves toward a lead gives us a positive waveform, and any impulse that moves away from a lead gives us a negative waveform. Have a go at the following interactive exercises and case studies. Don't worry, your marks are not logged anywhere and you can try as many times as you like. Good luck! To end this module, we will learn how to calculate heart rate. Now, most monitors and ECG machines will give you a heart rate, but it doesn't hurt to be able to roughly work out the rate in your head. The heart rate alone gives us many clues as to whether there is an abnormality present. There are many ways to calculate heart rate, but I will give you two methods to start with. Click on the links to learn more. Method 1 works well for regular rhythms. Count the number of large boxes between consecutive QRS complexes. This is also known as the R to R interval. You then divide the number of boxes into 300, and this gives you an estimated heart rate. If you want to be more accurate and have a calculator to hand, you can also count the number of small boxes and divide into 1500. Counting out the number of large boxes in this example, we can see that we have 6 big boxes between QRS complexes. 300 divided by 6 equals 50 beats per minute. If on-the-spot maths isn't your thing, alternatively you can jot down the following. Method 2 is good for fast and irregular rhythms. There are several ways you can do this, but they are all based on the same premise, which is assessing a short period of time and multiplying that period of time up to 1 minute. Nurses do something similar when taking a pulse. For this example, I'm going to use a time period of 3 seconds, which is 15 large boxes. The next step is to count the QRS complexes within that time period. In this example, there are 12 QRS complexes within 3 seconds. Next, we need to multiply that number by 20 to get the beats per minute. Therefore, 12 multiplied by 20 gives us a heart rate of approximately 240 beats per minute. Have a go at the following interactive exercises and case studies. Don't worry, your marks are not logged anywhere and you can try as many times as you like. Good luck! You have reached the end of this free module, and we very much hope you've enjoyed the presentation. We have much more free stuff available on our website, and if you have any questions, please do not hesitate to contact the team. Alternatively, you can post any comments or questions on our blog or any of our social media outlets. If you have the time, please complete the survey on the next slide. Thanks for listening and keep in touch.